hello everybody. It's Brett Mitchell here with Martin Kiernan in person. Hello, Martin.
person, yeah. Nice to be back in Sydney. Nice to see you, Brett.
You too. And we've found an article in the Journal of Hospital Infection that we wanted to talk about today. It's on the topic of environmental cleaning, which is always close to our hearts. But it's called High-Touch Surfaces are not always high-risk surfaces in the ICU environment. It's from a research group in China, and Zheng is the first author. And what they wanted to do was to identify high-risk items in the context of fomite route transmission in the intensive care unit, and really differentiate between, or I guess determine whether there was a difference between high-touch surfaces and high-risk surfaces. And I guess they sort of hypothesise that maybe they're not always the same.
Yeah, I think that's fair to say that. Yeah.
So, Martin, what did they do?
Well, it's a small unit, and they had teams of people going in doing direct observations on staff activity, and they classed as an episode of activity, so a medic doing the ward round, etc., or a nurse performing a procedure. And they divided the staff into three groups: doctors, nurses, and what they call caregivers, which are like a nursing associate type of role, helping with positioning and that sort of thing. Now, it was interesting that they've got a unit there. They said that they had no interruptions in being able to visibly look at what all the activity was, because there's no such things as curtains in the unit, which brings some questions for privacy, etc. But anyway, that's, I think, possibly the pattern of work over there. The observers worked 12-hour shifts, actually doing the observations, which I think will probably overcome any Hawthorne effect, because after a while I suspect you become...
Just go back to normal.
Well, I think you would. I think you'd struggle to maintain, perfect practice for 12 hours.
Yeah,
I mean, so I thought that was
Do they know that they were being... They knew they were being observed.
They knew they were being observed.
But for what?
They didn't say if they knew they were being observed for what.
Yeah.
But they knew they were observing practice. So, you think...
Maybe their hand hygiene compliance was higher than that.
Well, they didn't actually report on that, so that's quite interesting. But they were looking at what people were touching and in what order they were touching, and they then went on to create some form of network analysis. So that was the method.
Now, network analysis is I've used it before, and it's a good way to look at movements. Well, that's my description of it. I'm sure there's a much more technical way to look at it. And I've used it before to look at movements within a room, which is essentially what they did, but instead of movements within a room, they looked at what people were touching. Yeah. And every time you might touch something or move something, it would become a point, a node. So you can sort of see patterns between where people move between things, or where there were crossovers between things that were touched from one to another, or a particular cohort, like the physician or the nurse or the caregiver, following a certain pattern in the way that they touched things and what they touched. It could also be used, as I say, for movements. I think I've seen it used in public health and outbreak-related things as well. So it's a good way to do it, to look at that sort of thing.
The actual number of contact sequences is quite interesting, because sequences for physicians were actually longer than those for nurses or caregivers, although the actual sequence included 31 touches on average.
31,
that's a fair number of touches that they're actually observing, and what they're looking at, what's going on there.
So some of the high-touch items they found were bed rails and patient's skin, and bed surface, stethoscope, end-of-bed tables.
That was the doctors, wasn't it?
That was the doctors, yes. I'm sort of mixing up the things a little bit here, but that's the doctors. What I was getting at there was that, when we think about high-touch items traditionally, if we were to talk about high-touch items in the context of cleaning, we probably wouldn't be thinking about a person's skin, for example.
That's also true, yeah.
So they sort of included this broader array, I would say, and that's probably part of this concept of what's high risk and what's high touch.
It is a frequently touched surface. Skin is a surface, and it's likely to be a very contaminated surface. Yeah. So actually, this was an interesting part of the study. They included skin in the sequence of contacts, whereas we don't tend to look at that in such a way, I don't think, previously. So that was interesting.
And just bear in mind, this was done in an ICU setting too, so which I know you're
Well, when they merged the actual surfaces touched by the three different types of healthcare workers, the highest touch surface, in fact, was the patient's skin, then the bed surface, then the bed rails.
Yeah. So now, if you think about that for a minute, this person's skin, the bed surface, and the bed rails. Traditionally, even the bed surface, we probably wouldn't think about. If you think about when you use UV dots in studies and in work to feed things back to environmental services stuff, we don't ever include the bed in that. I mean, they're not really cleaning. Let's not go down that route.
Difficult to do something with that. Really.
It is difficult to do something with that. I think. Yeah, I think that's where I was sort of going with that. Yeah. So anyway, yeah. And what about the high risk items?
Well, the high-risk items, they looked at just doing straightforward aerobic colony counts using swabs, which is, I mean, you don't know what the organisms were. They could have been just environmental organisms. There were other ways they might have done that. But anyway, that was what they chose to use, just ACCs.
It would have been fascinating to do this and something like ATP or something at the same time as that. But so I guess they ended up with these sort of Venn diagrams, looking at the overlap of where things...
And looking at what was high risk and high touch. So the high risk and high touch items were the bed rail, the bedside computer and the bed surface. And I'm not sure what you do about the bed surface.
No, and that was for the nurse, wasn't it?
Yeah. Well, no, I mean when they combine them all.
Okay.
So I think that's interesting because obviously the bed surface is going to be contaminated by whatever the organisms are present on the patient's skin. Or possibly from aerosols when doing suctioning, etc. The bed rail, that's obviously wipeable. Bedside computer, well, as we know, those are self-cleaning. Whose job is it to do those, and how often do they get done? I'm not sure about that. And actually, low touch, but high risk from an aerobic colony count items were the bedside medical chart and the PDA used to input data.
Yes.
Now, the charts often go under the radar, I think, because people do tend to pick them up, have a look at them, and if you're still using charts, or if you're using a PDA, maybe everyone's going to handle the PDA.
The thing I also, just as a side note, they broke this down as well, didn't they, by physician, nurses and caregivers. So you could see there were differences between those groups. And when you see the differences, it kind of a little bit makes sense. So the overlap for the physicians was bed surfaces, patient skin and bed rails. For the nurses, it was the end of bed table, bed surface and bedside computer. You can kind of envisage it. The thing that was interesting was the caregiver, because that was bed surfaces, patient skin, bed rails and end of bed table. But there are two things thrown in there. One is a high touch, which was the pillow. And a high risk, which was the therapy cart. Now, I wonder why the therapy cart was high risk in the context of a caregiver. But
I'd struggle to know that, but I think you need to look at practice and exactly what people are doing.
The
pillows I can see as being a high touch because patient pillows just aren't used under people's heads, are they? They're often used for positioning, for pressure, ulcer prevention, that sort of stuff. If you're moving people around, if you're proning them, you're going to use pillows. I suppose a high risk item is the therapy cart because no one ever cleans it. That's possibly high risk. I mean, how many times if you swab the average resus trolley, they'll check. People often check to see if what's in it is in date, but they won't necessarily clean it very frequently.
No, that's right.
So that's possible.
So I guess their conclusion to this study was that they felt that there was some overlap between high touch and high risk surfaces, but they're not the same, and that high risks were determined by what they call the centrality of the nodes. But in contrast, there was contamination levels found between high risk and high touch surfaces for certain things. So I guess for me, it probably just opens up the idea that, in my mind, I had a fixated view on what a high-touch surface was and assumed that everything that was high-touch was high risk, and it could still be. But this probably just opens my eyes a little bit more to other things that might be still high risk, but not necessarily frequently touched.
It made me think a little bit more about patients' skin. Because, we've seen a lot of studies from people like Susan Huang talking about chlorhexidine bathing reducing the risk of the patient infecting themselves. But actually, chlorhexidine bathing was used on people's skin does that reduce the risk of transmission? Would that reduce the risk of hand contamination because you're frequently touching the hand? I've never seen that study done. We know chlorhexidine has a residual effect on the skin for quite some time. It'd be fascinating to see actually what the effect of chlorhexidine bathing might be on hand touches. Now, I get in a critical care unit, and I don't know if that's practice in China, that you have the nurses stay with just that patient, or do they go between patients? But I suspect the caregivers, who are the most frequent touchers of the patient's skin, do go from patients to patients.
Yeah, I would have thought so.
So if the hand hygiene has to be absolutely spot on. So that made me think a little bit more about, are there other benefits to chlorhexidine bathing other than just protecting the patient from themselves?
Yeah, that's a really good point. Because in actual fact, we don't think about, and actually in a talk that I gave today, which was about an environmental cleaning program, and I put up all these points. And the first thing I actually point was patients. And, I put in brackets, I'm not going to talk about patients and decolonisation. But what we haven't traditionally thought about is the context of the patient and decolonisation. In the context of environmental cleaning.
Yeah.
We've just thought about it as surfaces, not the patient, and maybe the two are in one. Maybe there needs to be more thought given to, when we talk about cleaning the environment, is there a subset of, is there cleaning and one subset's the environment and another is the patient? I mean, of course, that's decolonisation, but the interaction between the two.
I mean, there is obviously interaction. I mean, that paper from Eileen Wolfensberger that showed 70% of environmental contamination is from patients if they're mobile, so they're moving around. Now, they're in critical care, they're not going to be mobile, but their skin is still going to be contaminated, and therefore we can be the mobile agent. So it just made me think slightly differently about that, and I'm wondering if there is a study there that would show a reduced risk of transmission using chlorhexidine bathing. Is it an intervention that is a bit more horizontal than vertical than we thought?
Yeah. Because I don't think this, maybe dichotomy is not quite the right word for it, but the dichotomy of endogenous and exogenous transmission, I think, is not black and white. And I think there's a big grey area and overlap between the two. At what point does a person become colonised in the hospital with hospital pathogens and still infect themselves? So I think there is this big overlap, and the environment comes into that. Chlorhexidine bathing comes into that.
Yeah.
A lot more to be.
I'm not sure if I understand really what endogenous and exogenous is anymore.
No.
If you come into hospital and you become colonised in your gut by MDR gram negative, which at a point we won't know because we don't sample people all the time, but it's possibly doesn't take too long for that to happen, and then you get a UTI a week later, I think that's endogenous because it's your own flora. But some people have said, oh no, there's that exogenous because it wasn't your organism. Well, it wasn't to start with, but then again we were born with no organism, so I'm not sure at what point something becomes endogenous or exogenous, and it might make us think a little bit differently.
And also explain some of the results we see in other working papers too.
Yeah.
All right, man, always good to chat with you.
Short but sweet.
Yes. Thanks everyone. Thanks for listening to the latest edition of Infection Control Matters.